Okay. A couple people have made disclosures which I didn't realize we were going to have to do. And so the only disclosure I think I have to make is that I started my career as an optimistic and idealistic young man. I'm now sad and broken, and so we'll start there. The other thing is the art of being a reaction person is like to link to the comments of the main speaker, but then end up saying the things you were going to say anyway, which I'm definitely going to try and do here. But actually, this is going to be relatively easy because Helen said a few things that I think are very relevant to my comments. So let me actually start there and try and do what the job was asked to do. The first thing that she said is that, or somewhere early on in her comments, she said, evidence is mixed, and it's hard to translate where the evidence is coming from, particularly, and she may not have said this, but in my mind, to fee-for-service. The evidence is very mixed, and of course, in our environment, people are pushing very hard Medicare. I'm going to be speaking about Medicare here for the most part. Medicare needs to pay for all of this stuff, but the evidence exactly is not really come together. And the thing that I keep observing, and this is not the same thing, and not just true of telehealth, this has been true throughout, my career, is people come with evidence out of a managed care environment or a VA environment or some other kind of environment that's not like Wild West fee-for-service, and they say, do this, it will work. And the answer is it will not work. It will be completely sidetracked when it gets into Wild West fee-for-service. And so there's always that disconnect. And I think it's a very hard bridge to get across. However, along those lines, to try and be a little bit optimistic, and again to kind of go back to something Helen said, is she said, we shouldn't assume that technology leads to improvement, and she said also around the same time we should be thinking more about bundled payments. And I also have had this experience over the last few years, and I would think about it this way, which is I have so many people in my past job approaching me saying, I have this technology, assign a code, assign a number to it, and pay for it. And I think that is precisely the wrong way to be thinking about innovation, whether it's telehealth or any other kind of innovation. And I get my background and my experience and everything, and so I'm highly biased. It is not about that. It is about payment systems that can accommodate change. That's what we need to do, because technology is going to change. The way you practice medicine is going to change, and to the extent you're doing it through piecemeal assignment of codes and payments, you're on the wrong track, because most of that is going to be obsolete in many years anyway, and so why proceed that way? Not related to my comments, but a really good one she made is that this needs to be built into the medical education process. In some earlier work, I saw the same thing where people are just, what are you talking about? I had no experience with any of that, and so I don't know how to proceed once they get out into the field. So I completely agree with that. Okay, so then to kind of, so the two things I've said so far is that there are mixed results in the research, and it's often coming out of environments that are hard to translate into fee-for-service. May be very helpful in Medicare's managed care programs or other bundled payment environments, but difficult to cross over into fee-for-service. And the notion that payment systems need to work more towards larger units of payments and leaving flexibility for providers. And Medicare is generally pointed to as the big problem with telehealth, and everything could move forward if Medicare would just get a clue and kind of get on with it. And lots of activity at the federal level in trying to integrate telehealth into the Medicare program. And so now I'm going to try and systematically address that comment. So one thing to keep in mind is a third of Medicare is in managed care plans, and managed care plans do have flexibility to use telehealth. Now, there are some technical arguments going back and forth, which I will be happy to get into in a lot of detail, but there are some technical comments going back and forth about how bidding works, or in other environments where I get approached by home health agencies who get 60-day episode payments, and they say arguments like this: telehealth, remote patient patient monitoring will save you a gazillion dollars. You should increase our rate. And I never follow that argument. They have a 60-day bundle. They say it saves them money, but they want Medicare to increase the payment in order to pay for the telehealth. That does not logically make sense. So my argument here is we should be moving to capitated managed care environments. When an accountable care organization takes two-sided risks, they should be relieved of the fee-for-service regulations and allow them to cut through and start using telehealth how they see it should be done. And in bundled payment environments, which I believe a lot of flexibility exists in the DRG and the home health environment, providers should be moving to it. Now, where things fall apart and things become very complex is when you hit the true fee-for-service environment, and in particular the physician and clinician environment, where you're paying service by service, and things do become more difficult there. And in assessing that, you will, whether you like it or not, have to think about the cost. And if moving to it is ultimately scored as a cost, that's going to slow things down. But if the case can be made on improving access, and particularly access to needed services, or if the case can be made that outcomes will increase, then obviously the case is more likely to go forward. Now, one thing I want to say, and Helen touched on this as well, is I also think from a policymaking point of view, you need to distinguish between access and convenience. I think of access as getting access to a needed service. Convenience is different. I have access to this service. Do I want it more conveniently or not? And you might, from a policy point of view, think of those two situations differently. And I can talk more about on question if anybody wants to get into that. So how should fee-for-service approach this? Here's a few thoughts, and thinking about it if you wanted to move forward in fee-for-service and in a principled way, and I'm trying to stay on time here. So one is, can you create white space in your fee-for-service payments? CMS is definitely trying to create codes that say, okay, if you're involved in transitional care, there's a bit of a white space here, and you can engage in activities. Another idea is whether you move primary care payment off of a service-by-service reimbursement and try and give part of the payment that you give to a primary care provider on a per-patient basis. So each of their services not, in fact, driven by a service-by-service interaction, but they have the flexibility to engage in more telehealth type of things. Another approach, in order to move ahead but not necessarily blow the lid off of the budget, is to come in on a condition basis and say there may be certain conditions where at least the exposure for fee-for-service is small enough that the risk of going in and doing telehealth is not that great. So, for example, if somebody's doing home dialysis, you might say they can do their visits with their provider through telehealth. And the notion there is that's not going to blow the lid off of the program because people aren't trying to become dialysis patients or Parkinson's patients or that type of thing. There are certain telehealth that is starting to prove that even in a relatively uncontrolled environment, it may have an effect. I am watching closely the nursing home link to the emergency room. If that could be established, that might work. But of course, the better way to go would be to start paying on a bundled basis in that environment and then saying to the provider, if this makes sense, go ahead and do it. And then the last thing I'll say, and I'm done, is remember, in the high-risk areas, there is always a CMMI and Innovation Center strategy here. So the direct-to-consumer stuff where I touch my tablet and I connect to my doctor, which could have the potential in fee-for-service to be very expensive, could be tested through an innovation environment to see what the actual induced demand effects are in an environment like that before it's let out into the Wild West. And I will yield the last 19 seconds to the next.